Hi, and welcome to another training video for sugar simulation use for global away rotations. This video provides a real-time look at a sugar case in session. In this scenario, we will be doing the DKA case downloadable on sugarprep.org. As a reminder, if you haven't reviewed the case overview or downloaded it yet, you should do so now. You'll want to follow along with the 2-page case guide while watching the video. Be on the lookout for the many obstacles put in the way of learners when they wish to do something they would expect to do back home. Part of the proven benefit of sugar is its ability to elicit complex emotions that mimic those often encountered in resource-limited settings in the safety of a simulated environment, as opposed to thousands of miles away from home. The DKA case demonstrates well the frustration providers can feel when faced with managing a patient without the resources they are used to having, and the empowerment that comes from the dynamic problem solving needed to overcome these limitations. You'll note on several occasions that one possible solution leads to several other obstacles on its own without you as the facilitator needing to intervene. After completing this video, you'll want to get out your debriefing script and follow along with the debriefing video involving the same learners. Finally, while the DKA case does demonstrate well the frustration and empowerment often encountered as discussed earlier, other cases in the curriculum address more challenging emotional triggers, such as perceived futility, dealing with cultural differences surrounding end-of-life care, and mismatched expectations among providers around the urgency of a situation. To see this in action, be sure to view the other video tutorials on sugarprep.org. Let's get started.
So now that we've all introduced ourselves to each other, one of the things I like to find out is what experience you've had in a simulation environment, if any, in your past.
I've never done it before.
I've done some mock codes during residency.
In medical school, we had kind of some sim cases with intubations and things like that.
I've done it several times during residency.
Okay, so what I'd like to do is orient you a little bit to the environment of the simulation center and what it is, what our goals and some of the rules that we have. Well, first of all, the environment is one where we try to reproduce whatever your environment you're going to be in real life. And so in this case, it's going to be a global health rotation, and so the environment will reproduce, that we will reproduce, we'll try to simulate that. Environment of low resources. The mannequin itself may or may not be able to do certain things, such as breathe or have a pulse. If you're unable to find out what you need from the mannequin, if you just verbalize that out loud, or if you verbalize what you want to know, we can then give you that feedback, whether the mannequin should be able to do that or not. If you need anything or want anything, you just need to ask, just like you would in real life. And what we would like you to do is to try to suspend reality a little bit, meaning that we can't make this just like real life, but we want to make it as much like you would practice in real life. And so it's going to be very important that you try to behave and ask questions and do things like you would if you were on one of the wards or in whatever environment you were in. The second thing I'd like to say is that this is a safe environment for practicing. The simulation environment is meant to be a practice area, just like a sports team or musician would practice before they perform, and that's what we're trying to reproduce here. In the context of what we're doing today, this is a training session, which means that we want you to do things just like you would in real life, and if you make mistakes, it's a safe area where later on we can talk a little bit about how you might change what you did. So this won't affect your training records or anything like that, or your performance. It's not a competency evaluation. Finally, after the scenario that we give to you, we will have a debriefing, which is a very important part of simulation. It's a time for us to reflect on the performance, to talk about things that we did well, to talk about things that we might do differently in the future. It's also a time to ask questions and to learn from each other. Do you have any questions at all about the experience that we're trying to kind of go through today.
Mhm.
Okay, we're going to take a short pause and then we'll come in and start with our first scenario.
You're called to the casualty ward to see a 5-year-old male with vomiting and lethargy. You have access to a nurse and the patient. Want to know exam finding? Perform the exam and ask for the finding out loud. You also have a parent who can help you with your history.
Can we get started?
Go ahead.
Yeah, okay.
Okay.
Hi, my name's Dr. Fitzpatrick. I'm one of the doctors here. Nice to meet you. Do
Hi.
you speak English?
Yes, I do.
A little bit. Can you tell us what he's here for?
So he just has been not feeling well for about 2 weeks. He seems to be very lethargic and not have as much energy.
Okay.
What's his name?
His name is Patrick.
Patrick, how you doing? How you doing?
Does he respond?
Yes, he does. But he's not acting his normal self. He does a lot of mumbling and is not saying things that make a lot of sense sometimes.
Okay. How are his mucous membranes? I'm looking in his mouth.
They're dry.
Dry. Not crying.
No tears.
Yeah, take a
Quick
listen to him.
exam.
Do I feel good pulses here?
You got some pulses. They're weak.
Actually, I can really take the pulse.
And he's been breathing like that for the last several days as well.
And breathing like what?
So
He's breathing really deeply.
Oh,
Not
actually, never mind.
not especially quickly. You can get the respiratory rate, but it's deep respirations.
Okay. Has he been peeing very much?
yes, he's been. He goes on his own, but I know that he has been going.
Uh-huh.
So you said 2 weeks of kind of not acting like himself completely and some vomiting?
So the vomiting just started in the last day or so.
Any diarrhea?
No diarrhea.
Any fevers?
No fever.
24. Would you take a pulse? You want me to do it?
Anybody else been sick around him at home?
No, everybody seems to be healthy.
Has he had any weight loss?
I don't know. He's looks like he usually does. Maybe a little thinner.
Does he have any medical problems that we know of?
No, he does not have any other medical problems.
I'm looking for a rash. Do I see anything like that?
His skin's a little cool, but there's no rash.
Okay.
Capri feels okay.
How's the capillary fill on the toe here?
His pulse is like 90.
Takes a little while to refill, 2 or 3 seconds.
Okay. And can I feel pulses down in the feet?
They're weak pulses.
Weak pulses.
All right, sorry, I missed some of the stuff. Will you guys tell me what you know already? His respiratory rate's 24 and his heart rate is 90.
So a 5-year-old boy with about 2 weeks of illness. He has not been acting himself, hasn't been feeling well, but he's only been vomiting for the past maybe day or two. No diarrhea, hasn't had a fever, doesn't have any rash, has this deep breathing, and he's not very responsive to my exam. He seems dehydrated, not crying. Moist mucous membranes are not moist, but he has been peeing recently, so he's not that dehydrated.
And I'm sorry, his brother did have a cold 4 or 5 days ago.
Okay.
Seems to be getting better.
Has he had a cold at all?
He has not had any of those symptoms.
So it does seem like he's definitely dehydrated as of this
Mhm.
point in time based on exam measures. Do we have fluids available? Any type?
What type of fluids would you like?
What do we have? Do we have
I think we've got some lactated ringers. Sometimes we have normal saline. I could check for you.
Sure. Even would be
Okay,
great.
anything else you want with the fluids?
We need to probably put an IV in, so
Yeah.
do you have
IV
IV
kit?
supplies?
Sure.
Yes.
Yeah. I think we have a lot of those right now.
And what about labs?
Yeah.
We want to do a CBC,
How old is he again?
He's
5
5.
years old.
Should probably check the glucose too.
Check the glucose,
Might be low, might be.
CBC, BMP. Anything else? Have cultures going.
What would you like first? Would you like me to get some things from the lab, or would you like me to give you the IV fluid?
Can we do the
Can we
glucose
do
quickly,
the-
or does that
yeah.
have to go to the lab?
Let me see if I can find our glucometer. It depends on where it is, but I'll go look for it.
Okay.
Alright.
We should get
Was
the
his
fluids going
belly?
pretty quickly.
Yeah. Was his
Yeah, I
belly
didn't do a
nice
belly
and soft?
exam.
I
I
didn't do a
did that.
belly exam. How's his belly feel?
He's not complaining.
All right.
Doesn't.
And he's moaning and kind of intermittently up there.
Should we finish examining him too?
Yeah, let's just do our complete exam.
I'll start with his head. Does he have good range of motion with his neck?
He's not, doesn't seem to complain about it.
Okay. Nothing that you looked at the arms and
I looked at
everything?
the arms and the chest, I didn't look at his back.
Okay.
I don't see any riches.
Like,
I did find our glucometer. I'll go get the IV fluids. Great. Next, his heart rate is actually 182.
Oh, okay.
Oh, faster. All right.
Usually 50 days. Do we have one of those tapes? What are those called?
Braslow.
Braswell tapes?
I don't have
Braswell.
mine.
I don't.
Okay.
Can we guesstimate?
Do we need to open this plastic bag or?
Yeah, we got 20 kilograms.
20 kilos.
Give him a 200 ml bolus.
You're guessing he's 20 kilos by? Okay. How much fluid do you need him?
200 mils. How many strips do we have?
We have like 20, but hopefully we won't need that many.
Good.
Just to let you know, those are all the strips that we have until the next shipment comes in next week.
Hopefully we only need one.
Hopefully we won't need.
Did you take this place?
I can't see we get it to turn it off.
I
feel
did,
that's
I
fine.
didn't think about that.
Okay.
So,
Just making sure I didn't.
Pretty fucking.
Oh, we can't seem to get it to turn on. So if we don't have batteries,
Look, there it's on.
Ah,
There we
Just
go.
need to put
I just
this
had
in.
to hold it.
What is that you're doing?
Checking blood sugar.
We're just gonna get a little blood out of his finger with this little sticker and check what his blood sugar is.
So sometimes if kids haven't been eating or drinking recently, their blood sugar can get low, and that could cause them to feel sort of out of it or sleepy. And so we just want to see how it is.
The blood sugar comes back as high.
That's all it says is high.
Just reads high.
So that's
Huh.
above 300.
Probably about 500 or either
500 or
500 or
600.
600.
Yeah.
Okay. So
I have some IV fluids for you.
Great.
I
What is
found normal saline.
Okay.
I've got tubes if you want to draw labs. Usually it takes 2 or 3 days for the labs to come back right now.
Okay.
But there's a tube if you want it.
Okay.
Okay, so let's
I don't
stop
think
and
we
think
need
here.
to-
Yeah,
Yeah.
I think we're
right now.
Blood sugar is reading super high and he's breathing really deeply and he's dehydrated but still peeing.
Right.
I'm thinking diabetes. DKA.
So I think we should still bolus him because he's pretty
Yes.
tachycardic.
Mhm.
So we should try to get him close to euvolemia, but we also need to get dextrose fluids and insulin. Do we have any fluids with sugar or dextrose in them?
Yeah, I can go look for that.
And do we have insulin?
I think so. I'll have to go to the central
Okay.
pharmacy.
Okay.
Do you want both of those together?
Yes.
Okay. Here is an IV pole if you need it. I'll go look for those things.
Thank you.
Need a place to ID?
We have
You know, will I have to pay for the?
What was that?
Do you know if I
Right.
have to pay for the labs?
I don't think we're gonna get
Medicine?
any extra labs right now. So his blood sugar is really, really high, okay? So it's opposite of what I was talking about before. So have you ever heard of diabetes?
Oh, I've heard of it.
Okay, do you know anyone with it?
No.
Okay, so what happens is when people have diabetes, they are unable to keep their blood sugar normal. And sometimes it can get very high. And when it's very high, it can actually cause them to have, kids to have issues thinking or behaving or moving or even breathing, which are all the things that we're seeing right now. And the only treatment is something called insulin, which helps bring the blood sugar to a safer range. And so that medication is something that we would like to give him. I don't know how much it costs. Would you like me to find somebody who can help you figure that out?
Yes, if it will help him. Can we fix him or can we help him?
The insulin will definitely help him. Yeah, if we can get his blood sugar down, the insulin when the insulin will do that, that will definitely help him.
Yes, thank you.
Okay.
So I just got the IV, I haven't hooked up the fluids yet. Is there any labs, if we're thinking now DKA, that we definitely want, or do we want to try and go without and just use it?
If we're not gonna get him for 3 days, I don't think that would be
Right.
helpful at that point,
That's
so I
kinda
don't
how I
think we
feel.
need any
Okay.
labs.
Okay, so we'll hook up, so we have normal saline for right now.
Okay, and what are we giving him right now? You said
So we'll
200?
have to
200
see-
mL.
And how are we giving it?
Well.
Turn on
let's
the
see.
pump? No?
Yeah.
So, I have no idea what this is.
So can we just
Can we just
let it
squeeze
drip
it?
in at
Can I
full?
just squeeze it in?
How fast will it go if we just let it drip in?
Whoa. That fast.
That's
well,
dripping
maybe
into there.
Here, right, you count.
starting
Then I'll only do like
So-
some drops, so maybe. That's kind of open, it looks like.
Looks like it's open, yeah.
So, what about this down here?
Oh.
That's open.
That's open, what about this?
So, okay, so we don't have a pump, so we have to figure out how quickly, right, it drips. Oh, it's open.
No, it's open.
Okay, that's good.
So we should count.
It's not, well, we're giving a bolus right now, right?
Yeah, so I mean, I think as fast as it can go is gonna be.
Right, but we have to figure out how much we want to
We want
give.
to, we need
Oh,
to measure
right.
200
Oh,
in
right.
here.
How much is in there?
So this is 100 mils
150.
here, so we did this from 150, and then we did another 50 for
Okay,
St. Hugh's.
so I closed this, so everything in there should be what he's
Okay.
gonna get, right?
150.
Will it still drip when that's closed?
Yep, that's still dripping.
Here, there, look.
Yeah.
Oh,
Still
right there,
going.
okay.
Yeah.
Okay, we're gonna be going, okay, perfect.
I think
That's
two
going.
over.
I'm on some insulin. We do not have any glucose-containing fluids.
None.
Okay.
Mm.
Okay. Do you have any dextrose at all, even vials?
Yeah, we might have like, one of those like D50 things. Let me see if we've got any of that.
Sure. The other
Okay.
thing, do we have any urine dipsticks at all? So we can use that to monitor the ketone level?
Yeah, let me go try to look for some of those too.
Thanks.
Okay.
Okay, so what do we have there?
So we have insulin, 100 units per mil.
Is it regular insulin?
It just says insulin.
Mm.
Hopefully, yes, regular.
So I would probably assume it's regular, but we can try and ask if they know. That's all it says.
Probably safe to assume it's not Lantus.
Yeah.
And she gave us a syringe.
This was for the blood draw. I think we'll have to verify, get a syringe. Oh, there we go.
Oh.
That's a big syringe. Okay. So we're gonna get our dextrose, and then obviously we can't do a drip of insulin. So I'm trying to do sub-Q.
So I think we can do sub-Q the same way, just kind of give it
Intermittently.
intermittently. So do the 0.1. He's 5, right?
He's 5.
So we can do 0.1 units per kilo sub-Q every 2 hours, and readjust based on how things are going.
Dad, do we
Oh,
know
don't
how
have
much
any
he weighs?
dextrose fluids.
Right.
Makes me nervous.
We've not weighed him
For a long time.
a long time.
Does
Since
20,
the
I
first-
wonder-
does 20
they
seem
might
reasonable
have
to
a-
you guys?
Units?
20 kilograms?
Oh.
As an estimate?
I don't know. Just all depends.
He's fairly skinny. He's 5 years old.
I think that seems like a lot,
The nurse
actually.
weighed
seems
him,
very
they
high.
weighed him
Five.
when we first
When he first
can
came
ask
in.
her.
Here's the
Okay.
chest
to the
nurse.
hospital, but
And they may have one of those.
Well, and she
Rather
waited,
than-
that'll be
Yeah.
accurate anyway, so. Okay.
Okay.
Yeah, because that would be like,
We'll need to know that to
So
figure
if he's
figure
20
out the right
kilos,
insulin
right.
dose. And when she comes back, we can ask like what his mental status is like, because one thing we can do if he's not
can ask
actively
that,
vomiting or is responsive is that we could drop an NG and give like ORS if they have it or some juice or something like that to help with the sugar.
has he been vomiting like in the last couple hours or what?
the last time he vomited was 2 hours ago.
Okay.
And he's still not really making sense or talking much.
So he's still very sleepy and
So
confused.
So I think we should go ahead and once we get everything we need to do to get some, figure out the IV fluid rate that we want and get some insulin on board. We'll just want to be really cautious about the sugar level and then have a plan in mind of either being able to drop an NG and rehydrate him if he hasn't become more alert by then, or if he's able to take by mouth, then we can have him start sipping on some juice or Oroas if we have it.
Okay. Is he still interacting with us?
He's minimally
Still-
interactive, actually.
but still
But he's
the same.
moving.
Okay.
Wonder if they have any heart rate monitors, because we just worry like we aren't gonna know what his potassium and his phos are, and it'd be nice to like see. I'm sure, I don't know if we'll be able to monitor
Yeah,
him
it
though.
Mhm.
sounds like he's still making urine, and so I think we can assume that he'll be hypokalemic. At least total deficit, whether or not he has hypokalemia right now. So I think if they have potassium, we should think about trying to add it. But we can also, again, add that through the fruit
Later.
juice or coconut water or anything like that. If we have it, we'll have potassium that can help with that. I think the biggest thing is getting some insulin started
When I
after
feel-
this bolus is done.
His pulse definitely seems to have decreased since starting the bolus, although there was some discrepancy in.
Right, can
You
we
can
get
ask
a
for
recheck
pulse.
maybe?
What is his
Medical
pulse now?
assistant?
His pulse is now 172.
172.
Is our bolus done, guys?
Did you guys?
Just
No.
go
It's,
and got 50.
did you guys weigh him when he came in?
I think that they did in triage. I think he was 20 kilograms.
20 kilos.
Good guess.
Right on.
Here's some urine dipsticks.
Oh, great, thank you.
If you would like to check, then you can use this as a urine sample.
Okay.
So we're just seeing if he has ketones right now, just where we start
Yeah.
from, or
Yeah.
do we need to check it right now, or should we just assume? I'm just wondering how many there are.
That's
Yeah.
all we have for the hospital.
Yeah, I think we can wait and
Okay.
see kind of where we're going. That's a good idea because we
Good
know
call.
based
Mhm.
we know
Because
based
the
on
one-
his symptoms that he's going to have moderate to large ketones right now. It seems like.
So do we want to
Did
do
we
2
get-
units per? We got 20 kilos for the kids, so
Did
2
we get the
units per.
dextrose?
Somebody ran to get it, but it's we need to purchase it from a different hospital, so it'll be a little while.
And you said to give 0.1 per kilo every 2 hours.
Yeah, I mean, if we don't have the dextrose on hand and he's still not responsive, it might
So maybe-
be reasonable to do like 0.05 units per kilo
Right,
instead
because
of
usually
0.1
give it as
to
like
be a little
a
bit more.
continuous infusion, right? If you give it as a sub-Q, is that?
And we give 0.1 per
It'll-
kilo
Or is
per
it
hour.
fine?
Yeah,
I don't
it's
know.
fine. Yeah, but I think if he's kind of on the borderline for age anywhere, you might like think about making that transition. So I think if we don't
Okay.
have dextrose on hand,
We should do
when
less.
he's not responsive, we should get some insulin on board, but
Okay.
wait for the dextrose before we
Found him.
maximum. All right, so.
Okay, so what do we have?
So
Like, how do we
he
draw
has-
it up?
So, do you know if this is regular insulin?
We only have one kind of insulin.
Okay, great. So
Probably
regular.
not, yeah.
Do we have any like small syringes to give this?
Yep, I can get you a smaller syringe.
Thank you.
Okay, so our fluids,
What is the
we've
concentration?
got 100 in so far.
It's 100 units per ml,
We
so
want
we
to
might-
give
and we want to give one, right?
about 1
Because
unit.
0.05 times
Yeah.
20.
20.
1.
Yeah.
Yeah.
So we'll probably want to dilute this a little bit
Yeah.
because it may be hard to draw up otherwise.
Should we just take it out of this? Should we just dilute
This
it
is a
from here or
TB
something?
syringe with a very small needle.
Thank you.
We could take some out of here. Could do like how much would we have to dilute it?
We did
Well,
100 for
I think we should try to make it like 1 unit per ml. That would be
So we'd have to put in 1 of this and 99 mLs of water.
We don't even have a syringe that big, do we?
Do you think we
Yeah,
could?
we
Do you think
do.
we could just dilute it to 1 to 10 instead, or 10
Are you
units per
gonna-
ml?
It's just gonna be, you have to be able to measure whatever you're
So
injecting.
the thing
Right.
is that this
So-
smallest this really comes is 1. Well, I guess you could get like a half an ml.
yeah.
Okay. Let's dilute it.
But then
Let's dilute it to 1
the
to.
margin of error is pretty intense.
Right,
One
exactly.
unit per
So that's
ml.
why I'm saying I feel like I would rather
So
do
That's
1
like
ml of
10.
this and 99 of water,
Yeah.
and then it'll be 1 to 1 then.
So if we did
The biggest that we have is 30 mLs. You're saying you want to do 100 to 1?
99 to 1. Pretty much
yeah,
the same.
what would we mix it in?
Well, right, but we don't have a 100 ml
To
syringe.
mix it in, that's what she's saying. So what would we do with 30?
So we'd have to do, we only have a 30 ml syringe.
That's what I was thinking. If we did
Could do-
1 to 9, then we'd have a 10 units per ml. Can we measure a tenth of an ml to administer, or is that? not
I
And
vomiting.
the
don't think
TB
not for
syringe
life.
should
Not
be
based
able
on this.
to.
Oh, okay.
To do what?
Alright.
To measure a tenth of an ml to
Okay.
Okay,
measure.
so then there.
Okay, so we'll do 1 of this to 9 of normal saline
Right.
to get
So
10
let's
units per
squeeze
1
the
ml.
rest of what we need out of
Or we can just take it
here.
out of here. You can just
Right, but I
technically.
mean, let's
Just
just
to get our
finish
bolus.
what we need. That way I can then take this. I don't have to worry about interrupting the line
I
multiple
know, I
times.
think you can just suck it right out of the bag,
Okay.
technically.
Careful, doctor.
Oh yeah, I should probably have gloves on. Do we have gloves?
I can
We can
spread
put
you a pair of gloves if you'd like.
This part's probably okay.
Hole in the bag.
Well, we just did.
It's just such a small hole, it's just gonna be slow.
So we want 30.
We want 9 ml.
Oh, we are gonna do just 10 mLs?
Yeah, she
Yeah.
said that it's fine. So
Okay.
just that we can do 10th of
We
We'll
need
need
like
a
a
reliable-
connector. We're gonna put it in from one into the other. We need like a connector. Do you have?
I don't know. What does
I
a
don't know what those
connector
are
look
called.
like?
They're red.
Like a T-piece?
Yeah.
I don't know what they're called.
Let's see. Can you just put one into your leg?
Like not sterilely.
Mm,
Mhm.
just draw it up.
Yeah. So that. You just push it
And
through
then
the back
what?
there.
Yeah, you hold it upside down.
These are harpoons. So, what are you doing? What's the
She's gonna,
plan?
she's gonna have 1 ml of this,
Yeah, and then what?
and then we'll have to find a way to get it into that syringe.
And then some will be diluted, but we'll need to find a way to get it.
I mean, can,
I think I'm just gonna have to stick this needle in that. So just cover that needle, and then take it, and then unscrew it.
Excuse me, sir, do these, do these,
Is this empty? Why is it still draining? All right, let's just stop that for a second. Focus on one thing at a time.
did you already stop it?
I think so. Is it still going?
No.
Well, you're gonna have to turn yours upside down.
It's gonna spill.
You're right. Well, that's okay. We don't need it all, right? We
Well, we're
just
gonna use
need-
it again in like in 2 hours.
No, I know, but I don't need to fill it all the way up. So
Oh,
I can just
right.
go to like 5, right?
You only need 1 ml, yeah. Right?
Yes,
1 ml.
1 ml
Yes.
per time.
Okay.
We just diluted
Yeah, I
it
don't think we want one.
10 to 1.
It's not 10 to 1. Oh, so we
So
want,
there's
so we want
10
0.1
units
ml.
per ml.
0.1
So we
ml.
only want 1.1 ml.
0.1 mLs.
Yes.
Good catch. Yeah,
Yes.
good
How do
catch.
you need that?
That would have been a lot.
Yeah.
That was
So
the
she said
small
that
syringe.
the syringe was smaller and you could do 0.1 from it. She told us that this was.
I know, but how?
I think we're
What do you mean?
imagining that there are
Pretend
different
this is
numbers on
0.1.
here.
Oh, okay, okay. Here. You can give it. And then are we gonna check his blood sugar, like how long after?
Probably about 2 hours, 1 to 2 hours. It
think
depends
that's
how many,
fine?
how
Yeah.
many, I forget
Not
how many
very
strips
many.
we have.
Maybe like
We don't have
8.
very many strips, so I think 2 hours. with
Okay.
the
How do we
next
know
time
if it goes
we'll-
low
I feel
then?
very bad, but I'm gonna just put this right back on.
Yeah.
Does everyone agree?
Cause
Okay.
yeah, we don't have another needle.
I guess.
Okay.
What if-
So I-
All right, now that you've given the insulin, we're going to move time forward a little bit. The patient has been admitted inpatient, and it's a few days later. Your team comes around to reassess how the patient is doing.
and is he on fluids or anything, or?
I believe the team started him on some, they called it maintenance IV fluids.
Okay.
Okay. All right. So let's see. Is he awake?
Patrick, how you doing? How's he been doing, Dad?
He seems like he's been more He suddenly just, this morning, seemed like he's less responsive.
Hmm.
He was talking to me after breakfast, but now, I don't know, since an hour or so ago, he seems very lethargic again, like he won't wake up and.
I think it's time to use one of those
Yeah. Check again.
glucose strips.
Is it Patrick, is his name?
Patrick, yeah.
Patrick. Does he do anything when we try to get his
No,
attention?
he just
or-
mumbles and he's very confused again.
Okay.
Much like when he first came in.
What kind of pulse do we get?
You can listen to his heart rate and it should tell you.
93.
Yeah.
It's on.
Here.
Yeah.
What'd you get?
What did I get? His heart rate is 90.
Oh, sorry.
Okay.
What did I get for the sugar?
The sugar is 1.7.
Oh, wow.
Low.
Okay, so we've gone the other way.
What does that mean though?
So normal is 4 to 5.5. That's about 70 to about, I just know that range, that's all I can tell you. So it's
So
significantly
what are we-
lower
what are-
than,
oh, so has he been eating or drinking at all?
When I left, he was starting to eat some breakfast. I had to go and find his brother, and when I came back, he was not talking to me like he was earlier. He had some food on his plate
Okay.
left from the food I brought to him this morning.
Do you have any glucagon?
Okay.
How's his? Yes, we don't have any glucagon, but that D50 that you asked about the other day did arrive.
That'd be great.
Okay, yeah,
Yeah.
we need
Would
that.
you like some of that?
Yes, please.
so we'll have to dilute that too.
again.
So if we want
So-
D10, it would be 1 to 4.
Sure. And he's 20, so if we're
20
doing
kilos.
D10, if we're doing D10, he went 5 mLs per kilo, so.
Mhm. 5 mLs per kilo. Okay,
Can't find this.
where'd you get that?
Yeah, why do we want 5 mLs per kilo?
That was 2. Is it 5?
I think you always try to equal out to 50, I don't know.
Oh,
You're right.
you're right,
It is 5.
that's right.
It's 2 if you're doing D25.
So, if
Oh,
we're
I see
doing
what
5
you're
mLs per kilo and he's 20 kilos, I
So
wanna do
80.
100.
80 mils. So 80 mils of the D10, right?
Oh,
Or no,
well,
100,
you're
sorry.
talking for the dilution, I'm talking total.
Sorry.
She's
Okay,
talking total.
So 1 to 4 for the dilution and 100 mLs of the,
100 mLs total
Of
of
the
the
diluted
dilution,
fluid.
and then to make 100 mLs, we wanna do 1 part
So we
to
need.
4 parts.
right.
Yes.
And so.
What's
that?
What fluid is this?
And so 20 to 80.
Would you like another
Yes.
bag of the normal saline that you had?
Yes.
Yeah, we're gonna
please.
need something to
Okay.
dilute.
Is this
This
that
is
D50?
D50W.
It's a lot of D50.
Yeah.
Okay,
Yes.
A vial.
so we should.
So we want 20 mLs of that.
Yeah.
use this, I guess.
Perfect.
Right. You just-
Yep. Why don't we put, you know, just hang these up and then we can kind of do the same thing. Do we access the other ones?
It's like a 2-bag system.
It is a 2-bag system, just.
2 different bags. Let's take this one.
Well, yeah, so you can, it's just full. It'll probably. Well, yeah.
I defer to you.
Whatever.
You've done a lot of sim before, so.
Okay. So you can just.
I know, it doesn't go in there, I need a needle apparently, I think.
Yeah.
All of those are insulin stuff. Do we have any more?
Can
Would you
we-
like another needle?
Yeah.
Oh wait, I think we can draw. That's
No,
true.
we need
Yeah.
a connector again.
Oh, okay. Yes, please.
Unless like, I don't know
Can't.
what any of this
Where,
stuff
where
is.
we go into the.
If you can like run it
Okay,
out
I'll
into
look this
something
up.
and
Are we
then.
going here?
Oh! Well, I don't know.
You can treat this as a clean needle
Okay.
to use. Not that one, the other one.
Yeah, look at that. How much did we want?
Which is this, the
This is-
D50 or the?
This is the normal saline.
saline? We want 80.
80.
So we should have
So
got this.
8?
8.
mLs? What, 80?
80.
80, so that's why.
80.
We don't have
Okay,
that big of a syringe, so we're just gonna have to do it in multiple.
Can we
doses.
we can't Y stuff in on us. We don't have that kind of equipment.
I don't know, does this work? I don't know what that is.
You can't get it right up on.
No, it's not connected.
Should we just break this off and use it as a receptacle to make a mixture? I mean, I know we're jimmy rigging, but, or this one here, the one that we're no longer using.
To hook it up to that one.
Okay.
I mean, just unhook it
The problem
and
is you
use it.
can't quickly fill and unfill it. Can you?
Sorry, this won't go right on there.
Hold this. for a second. No, this one.
Okay.
Oh, I have an idea.
Get it down to 80.
I don't know, I was gonna go to 50, but. that
Can you
was
just
my
verify for me
decision.
that this won't go on there?
Yes, yes, I can.
Thanks. In my brain, I
Okay,
felt
this
like
was a
it
bad
should fit.
position. We don't have any left in this. How do we get this off here?
Let's see.
How much does this one have? That one's close, we'll start with this. Okay, open this,
And that one's normal saline.
go to 80, yes. You see it, is it to 80 yet?
Yes.
Okay, take this. This is
I think we should
I just
retype
don't want it
this
to
up
like
this now to
drain.
get 80.
Yeah. Alright. Take this.
Oh,
Oh
dear.
god.
Good job making do.
I don't know how
Okay,
else
so
to do
now
it.
we
Okay,
should
let's
close
be
this.
safe.
This
Someone
is-
hold the bucket here.
Can I hold your bucket?
Okay, because this is gonna spill when I open it.
Don't get my sweater wet.
Okay, now watch it. You're gonna go to 100,
Yep.
right?
Yeah, but I have it closed so I can
Okay.
measure. Okay, you can move.
Okay, I don't think anything should be spilling anymore. And then what are we gonna do with it?
Give it to him.
Give it to him. It's not
As bolus?
running. There we go. Keeps moving. Oh, a little bit more. A little bit. Keep going.
Is he like
Stop, stop, stop.
seizing or
Stop, stop,
anything?
stop, stop.
Is he fine still? It's
Okay.
been kind of a while.
Yeah.
Okay.
Is he
But
doing
it's
okay?
just
No
normal
changes.
saline.
Yep,
No
he'll
changes.
still sort of respond
Okay,
moaning.
this
That
is
feels a bit
Empty. So this needs to be hooked up to his
IV.
IV.
He has
He
an
has.
IV. He has an
Close,
IV. We
right.
just need to
We just
exchange
need to
it.
exchange it. And then we just need to open it up and give it to him as fast as it can go. 'Cause,
Yep. Nope, not there, 'cause that's from the bag, so it's down here. It's this. So it should be this. These are open. Is it good?
It may be on its
Starting,
way.
I think it's just.
Okay. Nope, don't squeeze that.
No, I know,
Yeah.
this is close, okay.
Yeah.
There we go.
There we go.
All right.
Okay, a few minutes later, your patient improved from his mentation, is talking to the father again. And we're going to stop the case right here and move into our debriefing.
Okay.
We're going to spend the next 20 to 30 minutes debriefing the case with you. We're going to focus our attention on the emotions encountered, but also address the medical management of the case. Keep in mind, many providers find that managing a case like this abroad to be quite frustrating, and we want to be able to be sure to address those emotions during the case. So the first question I'll ask for the group who participated, how did that feel?
Clumsy.
Clumsy. Good word.
Yeah.
I mean, at the end of the day, when the child got better, it made the whole thing feel sort of okay. I felt reasonably good about the thing, but it felt like at any moment it was perilously close to going south and not turning out so well, and I didn't know how I was going to respond to that. It just felt like it was a lot more likely to go bad than it would have been back here in the States.
One, I felt like I didn't know how to, like the medical knowledge is so different than how we manage diabetes on a routine basis. So I was glad that other people knew how to do it with like using math and things that we just don't usually have to do when, you know, you admit a patient to the hospital, so.
Yeah, and I think we're all pretty used to just ordering things and not actually having to hook them up ourselves and play with kind of how they're going to drip. So I think usually our nurses do all that. So I think that was something we all obviously struggled with.
So it's frustrating not having, not being able to do the same things you might do at home. I hear that lack of resources is a little difficult.
It's true what she said. I didn't even think about that, but the lack of physical skills, the actual implementing the stuff that you want to do, having to figure out a way to mix things in a receptacle that isn't even designed to be used that way, and using syringes, I don't know.
Right. And you didn't have all the pieces that you even if you do some of that stuff from time to time with patients, the setup is totally different and not very user friendly at least. And then also I felt nervous about like not being able to manage him like safely, or what felt safely, like knowing his electrolytes or following up on his blood sugars as quick, things like that.
Felt a little dicey too, having to say, we have this many strips for the whole hospital for X amount of time. How do you prioritize the use of those?
Yeah.
And too, with the point that Dad had made about, how much money is this going to cost me for these labs, and are they necessary? So I think always remembering that. And then the turnaround time too, 3 days isn't going to help us at all.
Can someone summarize what the case was about from a medical point of view? Kind of taking us through what just happened? I just want to make sure that we're all on the same page.
So a 5-year-old boy comes in with 2 weeks of illness and recent vomiting, diagnosed by us with diabetic ketoacidosis, high blood sugar, presumed ketones based on the physical exam and his mental status and whatnot. And we resuscitated with fluids and with insulin in order to normalize blood sugar and get rid of ketones. And then we took it a little too far apparently, and he went hypoglycemic, so we had to give him some sugar back, IV, to get his blood sugar back up quickly.
And then what happened?
Sounds like he is back to, I don't know if he's back to baseline, but he's well, and he's playing and talking to Dad, so that's the very satisfying part of the case.
Yeah, thanks. Were you all on that understanding as well?
Yeah.
Okay. What aspects of the case do you think that the team managed well?
I think we all pretty quickly, once we got the sugar, I think there's kind of mutual consent into what the diagnosis was, and so then we all kind of went into, okay, now that we know what we're dealing with, like what things do we need, and starting to prioritize kind of the next steps.
It did make me think actually when that happened that it seems like in a lot of cases, the diagnosis, there wouldn't be such an aha moment. When we saw that blood sugar reading and it seemed like the diagnosis was pretty clear, I can imagine a lot of times when the diagnosis wouldn't be so clear and you'd still be humming and hawing and not sure. And that would introduce a new level of frustration, especially if labs aren't going to come back for 3 days.
Right.
I think we did a good job, prioritizing what we want once we figured out kind of where we were starting from, and a good job kind of communicating between us, not deciding not to check the ketones, kind of not contradicting each other, but kind of talking to figure out the plan that would be best with the resources that we had.
Yeah, it didn't seem like egos got in the way at all. Everyone was cooperative and collaborative.
Yeah, I can imagine that the stress level by yourself would be much higher. I mean, there are a lot of times where we kind of corrected each other or played off each other, so being in that situation by yourself, just wanting to triple check everything and not having somebody to run it by would be a little bit even more nerve-wracking.
Yeah, that's true. And I think about my friends who've gone on global health rotations, they always go by themselves to some place, not 4 people together, all walking around caring for the patients together at the same time.
Caring for one patient.
So that's true. That would be a different ball game.
Mm-hmm.
We sometimes used 4 and 6 hands at a time to do something that we were trying to do, and if you didn't have anybody available to help.
What do you think you might have done differently next time?
I don't know if we got a full history, like underlying medical problem. I don't know. I didn't hear. I wasn't doing that. You guys did SI. Okay, sounds good. I just was distracted.
We didn't go through
by
everything.
examining
We
it,
just
right.
went through, but we asked any previous medical
Okay.
problems.
Because we got through the blood sugar quickly, but like exposure to things that could make him lethargic or medications or other things,
Yeah.
If we hadn't had that blood sugar, I don't know
Right.
exactly where things would have gone next, but
Especially, I think we targeted our history and kind of didn't delve further when we felt like we had a reasonable explanation.
In this case, we did have, if we had needed more history, Dad seemed to speak English pretty well.
Yeah,
I do
very
wonder what it
nice.
would be like if we had a parent who didn't speak English well and didn't have interpreters, and I can just imagine how complicated and frustrating it would become.
So I noticed that during the time that you were figuring out your insulin dosing, and then especially during the D50 calculations and administration, that the patient and father were were not as much part of the scenario, and I was worried about how the, especially the father might feel about that. How did you feel about that as a team? What do you think was going on during that time?
I don't even know if he told the dad that the blood sugar was low. I think I was so distracted on like acting and figuring out how to act that, or like, you know, for the patient that.
I think you're right, because he even asked me a question. He pointed out that there was air in the tube. And I looked at the tube, and then it just blew Dad off and went back to care of the patient. Would never do that with a real patient.
Yeah, I don't think we did a great job at including you or the family and kind of our thought process. Like the only time we actually really included you was when you yourself stepped up and said, I can have to pay for that, like in the very beginning. So I think we definitely could have done a better job there.
And she did a good job right in the beginning involving Dad, trying to explain what diabetes was, but then we just kind of got on the care track instead.
And as the dad, I think I had a lot of questions and concerns, but I also saw that you were really busy, and so I was afraid that if I interrupted you, I might be causing problems with what was happening with my child, and so I didn't interrupt and didn't ask a lot of questions. But I had a lot of questions.
I think it's hard because like many of the times when you are in a situation like this, you can ask other people, like you can ask for child life to come or extra nurse to come or a medical student or someone to spend time with the parent if you feel like you're the one who needs to be thinking and acting. And so we probably could have designated one of us, but I don't think I think I thought I have no idea if there's anyone here who could come and help. And that's a constraint on the system, and Dad wasn't that vocal, so it's easy to just kind of forget.
I think I would have hoped that, so we kind of cut time for a little while, so after we got kind of things started, then we cut time to like coming back later. And my hope would have been, who knows if this would have actually happened, but that initially once we started getting him stable and we had the lines running and like we were finally at that pause, that's when we would have like pulled Dad aside and talked to him about everything we had done, why we were giving insulin, and done kind of, that would have been when I would have thought to kind of do that.
It was funny, I keep thinking though, here we are again, 4 residents. We'll never have that luxury. In a million years, we still couldn't have one person go over and save people. I blame myself.
It's a learning environment. You're not meant to figure out the case perfectly. That's why the debriefing is so important. What was your response as a team when there was some spills on the floor and things were a little difficult with the B50?
I think our stress, kind of nervousness turned into like a little bit of laughter. Like I felt like, because we were just so, like, how do we make this work? And a little bit tight. So.
And that's kind of a funny thing about it. It's really hard to get that sense of urgency and emergency in a sim, because if things were starting to fumble in a real life situation and a patient was depending on it, I wouldn't start laughing and making jokes. I would start worrying instead. And I mean, it's just the way sim is. Like you said, you can't make it 100% like it is in the real world.
I just felt like, what am I doing? I have no idea what I'm doing. I was just trying to find a solution to get him dextrose, and I was thinking that this is not sterile, like there are so many issues with what I'm doing right now, but I didn't feel like I knew what else to do, and so I just kind of,
I feel like we had a lot of times with like that we were using the needles and containers and things that I felt like this was not completely sterile or things that we would have done definitely, at least in a more clean fashion, right, in the U.S.
How did your team overcome some of the obstacles that you encountered during the case?
I mean, we used certain tools for purposes that they were not designed for, but that would work okay, like to mix up our insulin, to do with the insulin. We had to come up with some container. So we improvised, I think, where we could.
Yeah, I think we were lucky enough that kind of Teza knew necessarily some of the kind of conversions and things that we didn't have to necessarily go to our book, but I think we had it there in case we didn't know kind of how much we should be giving when we're doing sub-Q, because definitely we're more used to doing drips and things here.
I think just communicating too.
I was gonna say, I think we bounced ideas off of each other. There are clearly times where, we didn't know necessarily what the next best step was going to be, but I think we kind of arrived at a plan together, and that was better than any of us were doing it alone.
Right. So I think I tried to draw stuff up in the syringe and then it wasn't a volume, and then you came up with like putting it in there, but then how do we put it in there? I haven't even used one of those really before, so I was just trying to figure out how it worked and then how to get fluid in and out of it. And
Yeah, so I just noticed that you were trying to troubleshoot that, and it was laudable, action to try to do that. Is there any other resource that you, or anything else that you could have done if you were by yourself and not four of you, and you were in an environment that had limited resources or had different resources than what you had at home?
I mean, we could have asked our human resource if there is a
Right.
cabinet full of containers right over here, for example, or bigger syringes,
Or even,
or
I mean,
help us.
or how to draw off the bag.
I feel like, right, like the nurses are used to using the, not using the insulin pump or the IV pumps, and so they have experience in that, and we can just ask for help. But I think we were all trying to.
Yeah.
And we may
Thought
or
we
may
weren't
not have
supposed
been
to
able
ask for
give
help
that
or whatever, yeah.
but,
I think oftentimes
ask
she
for
was,
it,
in
certainly.
the beginning, she was gone a lot. 'cause
Right,
we
yeah,
kept
I don't think
asking
she
her
was
to go
in here
get
when we
things.
were doing that.
The second time she was probably in here because we didn't ask her for too much else, but in the beginning we kept sending her to go get different supplies and things for us.
And for those of you who've been on global health rotations, does that happen? Where people disappear for a while and you don't know where they went to do?
Yeah.
And how does that make you feel, or what when that happens? Have you been on global health rotations?
I
I was
have
gonna
not.
say
Anxious?
anxious and really a combination of anxious and frustrating depending on what the situation is.
Yeah. I think depending on if it's more of a life-threatening or like acute situation, obviously you're more anxious and stressed versus if it's just, you could get this kid this medicine and he could go home, but you can't find a way to get the medicine or whatever, that's more frustration at the system.
So for example, if I had said like we had sent her away to get the like normal saline and we were working on putting the IV in, but realistically I know I'm not great at IVs, and in those sort of settings I know a lot of the nurses who work in there can get an IV in like anything, and he may have been pretty significantly dehydrated and we made it pretty easy to get the IV in, but I think in a real world sort of setting that would have been a big challenge and something we could have asked and relied on the nurse to help us with.
I'd like to review a couple of the key medical management points of the case. I noticed that when you were figuring out the D50, you used sort of a calculation. What calculation did you use to figure those? How much you needed, and how did that work?
I was the one that said to do 1 to 4 because we were trying to get down to D10 because that's what we typically use for IV dextrose back home.
Yeah. Yeah. Have you guys heard about the rule of 50?
She mentioned the rule of 50.
Yeah. Tessa,
So-
do you care to talk about how that works?
Yeah, so basically when you're trying to treat hypoglycemia, you can, whatever percent dextrose you have, you can give that many, if you multiply that times the mLs per kilo, you want it to be 50 as your total.
Perfect.
Right.
So that was sort of helpful in figuring out your concentration of how much you were going to need to figure out your dose.
Yeah.
So you said percent dextrose times milliliters per kilogram?
Yep.
Equals 50. Perfect. So that's a nice rule of thumb that I think that you guys used well. And then the other thing I wanted to touch on was your, I liked that you used the sub-Q insulin dosing. How did you figure out your dose?
Well, I think I just knew it from previous use and experience. So, but
I would have had to look it up.
I think otherwise you, if you didn't particularly like know that offhand or know like the resources to go to look it up right away, I think you could kind of get an idea of, well, if we were aiming to do 0.1 units per kilo per hour and we're giving, the insulin sub-Q, you can try to, figure out what that would be over like a 12-hour period or something like that, and kind of break up the doses that way is one other way you could have done it.
Yeah. And remind me what dose the team decided on.
What did you dosing?
0.05
0.05.
units per kilo
Perfect.
because
2
of the
hours.
every 2 hours of regular because of not having dextrose on hand.
Yeah.
Or being able to check.
Anything.
Right.
Yeah.
So anywhere from 0.05 to 0.1 units per kilogram per hour would be maybe a drip rate, and then you aired on the side of the 0.05 units per kilogram per hour for your dosing. Perfect. Were there any other medical management questions that came up during the case that anyone wanted to review?
I have a question. How much fluid did you want to bolus him with, and how much did he end up getting? Do you know?
I think you got like 150.
No, we made it up to
You did
200, yeah.
refill it?
Mhm.
Yeah, I think
So it was
we
10
refilled
mils per kg was what we were shooting for his first bolus. Probably would have needed.
I mean, yeah.
And where did the fluid in that was a 1 liter bag.
It should have gone into that big bucket.
You're saying how do we empty a whole liter bag?
Yeah, I just noticed that the liter bag is empty now,
Yeah.
and
Honestly, that, like, I wasn't paying attention to that thing at all.
Yeah.
Which is obviously a patient safety issue. I mean, we're used to machines that you type it in and it beeps when it's done and it doesn't give too much. And I think that I started it and then I moved on. Probably one person should have watched it because that's how the air got in there. I mean, I
So you got
thought I
50
had
mils
stopped
per
it
kg.
from
Yeah.
dripping. So I don't know.
Well, but then we turned it back. I know we didn't.
I didn't.
I was trying to think when we were drawing but we used the other
That was
port.
nice.
The air was in when we stopped it from the bottom, right?
Mhm.
But I don't know.
That's a good question.
How big is that
so
bucket?
I just noticed that the fluid in the bag would continue to drip into the
It did, even though it
Like
was
the top wasn't
into
closed
the
off.
volumetric container.
Mm-hmm.
So as it was, the volumetric container was emptying, the bag was refilling it, and
Yeah.
so it was just something that I had noticed, and just again, I think you mentioned earlier that just familiarity with
Right.
with the equipment and the medicines, and so what do you think about that?
Another reason to like have someone who's an expert in the equipment to probably be responsible for it or have trained you on how to use it before you're in a situation where you're stressed and worried, because that's not a good time to learn how to use a new system, obviously.
Or even maybe to establish rules. I mean, again, we may not always have 4 of us, but we didn't have the luxury of having 4 of us, so we probably could have had like one person definitely keeping an eye on like the drips while somebody else was keeping an eye on drawing up insulin and checking sugars. I don't know.
Yeah, and I think it really goes back to the point of saying, usually when we're working here, we can say we want this bolus and then this spray, and then we don't think about it anymore after that. And so I think it never entered any of our minds again to double check that. And so, just now kind of moving forward, keeping in mind that really making sure we close that top half off once we've measured out, it would be really important, and really figuring out, going forward, how to really get that maintenance rate going after we've given a bolus and resuscitated.
So before we wrap up our debriefing, I think it would be helpful to have each member of the team talk about one thing you learned from this case that you might take on an abroad experience or might change your perspective on going abroad.
I learned how to essentially take apart and put back together a whole IV stand, so that was good.
I think the rule of 50 was something I hadn't heard of when you guys were kind of coming up with the rates right away. I think I could have gotten there, like working out the little stoic or whatever line, but just that you guys knew that offhand, like that was pretty handy.
I think the most useful thing I got out of this was the fact to use your resources, to ask the people around you instead of trying to make things up as you're going along. I mean, if nobody's around, you have to improvise entirely from whole cloth, but when we have a resource right in front of us.
I think rethinking how to manage, or what you actually need to manage the case effectively versus what would be nice to have was something a take-home point for me. So knowing how to manage the keto sticks and knowing when to save, to not check them when we knew the patient was in DKA, because we only had so many we could save them for later when we thought the DKA was resolving.
Great. Well, thank you all.
Thanks.